Hello, everyone, and welcome to today's collaboration series. We're so pleased to have so many people joining us from all over the world. I am Joni Watson. I'm the Vice President of Marketing and Communications for the Broadreach Group. Before we get started, I just wanted to take us through a few quick housekeeping matters. You'll see that there is a Q&A button on your bottom panel. Please feel free to ask questions throughout all the sessions, and our panelists will do their best to respond as we go. We will also be collating these questions and having a live discussion Q&A in the last 15 minutes of the session. Final bit of housekeeping is that we will be doing 2 polls where we would love to get your input and participation. I'll read them out throughout the webinar. We hope you really enjoy this session today. Now, it's my honor to introduce to you Chris Legrand, who is the CEO of the Broadreach Group. Chris joined us in 2020, which was pre-pandemic, and Chris has a long career in global health development, and he has a particular focus on data-centric and tech-enabled approaches to global health. So, Chris, take it away.
Great, thank you, Joni. And a warm welcome to all of our global health friends and colleagues from around the world. We're honored so many of you have joined us today for this webinar. In hosting this discussion on such an important topic, we hope to contribute to the professional discourse, sharing new ideas, insights, and lessons learned for the community, and more importantly, for the people that we all serve. Just a few quick notes about Broadreach before we jump in. Broadreach founded 18 years ago on the African continent by 2 committed physicians with a focus on access to quality, affordable healthcare, particularly for the underserved and vulnerable populations on the African continent, and then recently taking on those challenges in the US. We're headquartered in South Africa with more than 1,200 staff globally. Over the years, Broadreach has become a well-regarded regional health implementer, and today we run one of the largest PEPFAR care and treatment programs covering 4 high prevalence districts in South Africa. We do this work because of our vision for a world where access to good health enables people to flourish. And our contribution to that vision is to deliver value by harnessing health technology and innovation that empowers human action. We seek to deliver that value through 2 lines of work: our health development business, where we run major programs on behalf of health systems and donors, and our health technologies business, where we deliver solutions globally built on the Vantage technology platform. Now, we know that there are many voices in the fray right now globally with various perspectives and takes on COVID vaccines, from efficacy to equity, financing, and distribution. The reason we thought this specific topic was important today is we kept seeing all of this focus on all of these other aspects, but minimal focus on how to actually get vaccines into people's arms safely and efficiently. Ultimately, none of all the great scientific achievement around the vaccine development for COVID will matter if we can't get vaccine into the arms of people at the last mile. And there are enormous impediments to reaching that last mile, as many of us have seen and experienced. We see this as a critical challenge of our time to get high quality, safe vaccines to the last mile using the learnings of the past immunization campaigns from HIV/AIDS and other fights against disease. And we know it will require optimizing and balancing the already scarce resources and infrastructure on the ground, recognizing that hesitancy may exist at that last mile, and of course, all of the logistics challenges of transport, cold chain, tracking and reporting and training and the like. Many in the scientific community are also beginning to prepare us that this may not be over anytime soon, as we chase the variants and try to get to reasonable levels of immunity so that the global health community can rebound. Today, you'll hear from a distinguished panel of experts dealing with exactly these issues. They're some of the world's best minds trying to get the vaccines to the last mile. They bring varied and important perspectives, from the policy and equitable access to the structures required for sustained implementation on the ground. The panel includes representation from multilateral, government, and implementing communities. We'll hope to have some time at the end for questions and answers and discussion, but let's just jump right in right now with our first panelist, Dr. Tim Mastro. Tim is the Chief Science Officer at FHI 360, where He works across all of FHI 360's technical endeavors, leading efforts in research and implementation science, addressing integrated development, HIV and TB, reproductive health, contraceptive technology, and nutrition. Previously, Tim served with the CDC, the Centers for Disease Control and Prevention, for 20 years, focusing on global HIV, AIDS, and TB, and served as an EIS officer at CDC, receiving numerous awards, and he co-authored or authored more than 190 published papers and book chapters. Tim holds an adjunct professorship of epidemiology at the Gilling School of Global Public Health at the University of North Carolina, studied medicine at St. Louis University, and trained at New York City's Metropolitan Hospital, Mount Sinai School of Medicine, and the London School of Hygiene and Tropical Medicine. Tim?
Well, thank you, Chris, for that very generous introduction. And thanks to you, Chris, and Broadreach for inviting me to be part of this distinguished panel. Next slide, please. So in 10 minutes, I'm going to give a high-level overview of the COVID vaccine situation and end with some reflections on what the future might look like as we roll out vaccines. Next slide, please. So looking back, on February 23rd, a year ago, COVID-19 had not yet been declared a pandemic. That happened about 2 weeks later. But over the last 12 months, we've endured this remarkable pandemic with 111 million cases globally. And we think due to underreporting, especially of asymptomatic cases, it's probably a few 100 million cases so far. And the world has suffered 2.5 million deaths. We've seen consistently around the world that health disparities have been accentuated. People with inadequate access to health services, poor housing conditions, and occupations that force them to remain on the front lines have resulted in increased burdens of morbidity and mortality for those people that started off disadvantaged. So indeed, the rich have become richer and the poor have become poorer, and these strains are going to be felt for years to come. Quite remarkably, over the last year, virtually everyone in the world has become something of an epidemiologist, a virologist, and a vaccinologist. It's common to hear people talking about the basic reproductive number, exponential growth, the spike protein, viral mutations, and the subtle differences between vaccines based on messenger RNA, viral vectors, or protein subunits. So fortunately, this process has yielded at least 5 vaccines that are highly effective in preventing severe disease, hospitalization, and death. And it's these vaccines that really offer a path out of the pandemic. One of the first obstacles we're running into now in the early stages of vaccine rollout are the viral variants that are in the news every day. I show the numbers here: B117, first found in the UK, B11351 in South Africa, and P1 from Brazil. These are likely just some of variants, and we have to get used to an emerging viral pandemic that has different variants. So as we roll out vaccines, vaccine hesitancy is likely to be a substantial issue that we're going to have to address going forward. And really the main theme of my talk is that we need to settle in and plan for a multi-year marathon of vaccine implementation. This is not going to be a sprint. Next slide, please. So the New York Times has a really wonderful corona vaccine tracker. There are hundreds of vaccines in development. 37 have entered human trials. 20 vaccines have had large-scale phase 3 trials, and a handful have received either approval or authorization from regulatory authorities. And the colleagues that follow me on the panel will go into these in a bit greater detail. Next slide. So these are the leading vaccines. Again, they're in the news every day. The mRNA vaccines from Pfizer, BioNTech, and Moderna, a Russian vaccine based on 2 adenoviruses, the AstraZeneca chimp adenovirus vaccine, and then other adenovirus vaccines from CanSino and Johnson & Johnson. And my colleagues from South Africa will talk about the recent introduction of the Johnson & Johnson vaccine in South Africa. And then there's other products based on protein subunits and inactivated products. So again, it's a very dynamic time in vaccines, and we'll cover some of that today. Next slide. So the question before us now, as we just begin to roll out vaccines, and Dr. Tedros, the Director General of WHO, asked the question, are we headed for a catastrophic moral failure? And that would be a moral failure if the rich people in the world have access to vaccines, are able to protect themselves, while people in resource-constrained areas do not have vaccines and continue to suffer the morbidity and mortality of COVID. Now, if you think back two decades ago, we were facing a similar situation with HIV/AIDS. In the year 2000, a year of antiretroviral therapy cost more than $10,000 per person per year. Therapy was only available in wealthy countries, and there virtually no one in Africa was on antiretroviral therapy 20 years ago. This was a moral failure the world was enduring. It resulted in a dramatic response from the world that increased funding from 2000 to 2010 by 20-fold. There was about $1 billion being spent in lower middle income countries in 2000. By 2010, that was $20 billion, thanks to the Global Fund, PEPFAR, the Gates Foundation, and many national programs. So we need to actually have a similar response to COVID to avoid a catastrophic moral failure. Next slide. So this is a chart of doses administered. You'll see that Israel is really leading this with more than 80 doses per 100 people. Again, this is doses, not exactly people covered. UAE has also done a good job. And then below that, you see the United Kingdom approaching 30 doses per 100 people, the United States approaching 20 doses per 100 people. And you'll see way down there, barely perceptible at the bottom, is South Africa. So we have these tremendous disparities in distribution early on, and we need to make sure that this trajectory does not continue. Next slide. So as we address issues related to the production of vaccines, distribution, and all of the challenges of rolling them out, vaccine hesitancy is a major concern. Ipsos has done large surveys asking the simple question, if a vaccine for COVID-19 were available, would you get it? And globally, only about 3 out of 4 people agree that they would. And if you look at the trend from August to October last year, they all go in the wrong direction. Fewer people are likely to take the vaccines. There's complicated issues behind this. Misinformation plays a strong role, and just doubts and concerns about safety are major issues around the world. You'll see here that in the United States, where I'm sitting, the number is 64%, South Africa just about the same, and France has one of the lowest levels of inclination to take vaccines. Next slide, please. So at FHI 360, we believe that social and behavior change strategies can support vaccine introduction. Our SBC team this past year has developed a quick start guide to support the design and implementation of demand creation and advocacy for national COVID-19 vaccine introduction. You can download this guide from our website. It's very evidence-based and has useful tools that can be used to counter misinformation about COVID vaccines. Next slide, please. So it's a very simple design with a 3-step process. Step 1 is to define and understand the situation. It's a very collaborative process working across teams of implementers, constituents, stakeholders, and national bodies. Step 2 is to focus and create, and step 3 is to implement and adjust along the way. For each step, there are specific tasks and clear outputs for each step, and it builds on the global knowledge to jumpstart efforts. Next slide. One place where this is being rolled out is in Malawi. By the end of next month, Malawi hopes to receive, via the COVAX facility, 1.5 million doses of the AstraZeneca vaccine. They plan to prioritize healthcare workers, people with comorbidities, and those greater than 60 years old. And FHI 360 is co-chairing with UNICEF, the Risk Communication and Community Engagement Committee that's working with the government of Malawi to finalize the development and rollout of a vaccination demand creation plan. So this is just one example of the work that people are doing around the world to roll out vaccines. So next slide. So this is my final slide. And I'd like us to think forward, what is this going to look like in the future? Again, we're just 1 year into this pandemic. It's been an amazing process, but think forward a few years. If we actually do the right things and we're able to ramp up production of vaccines, sort out the issues related to implementation, overcoming hesitancy, and really get reasonable coverage of vaccines around the world, we likely look back and say, well, due to increased investments and commitment to health systems, we've led to global vaccine coverage. Now, of course, it won't be universal. There'll still be spots and pockets with poor coverage. You perhaps will need a vaccine passport to travel around the world, but we'll have to come to terms with a virus that's endemic. SARS-CoV-2 will likely become an endemic virus, requiring ongoing surveillance. It perhaps will be integrated into the global influenza surveillance. As you know, every year the world has a global network to do surveillance, to look at the strains of flu circulating, and the vaccine is updated on an annual basis to address the flu strains. Perhaps something like that will happen with COVID. We think the vaccines may need to be updated on a regular basis, perhaps annually, maybe not quite that frequently. The revaccination will likely be required for COVID vaccines based on the duration of immunity due to either vaccination or natural infection. We still don't know how long the immunity will last. And I just remind ourselves that we've come to terms with influenza. In the United States, where I'm sitting today, last year, just before COVID hit, we had a rather typical flu season. About 50 million Americans had flu, influenza, and about 50,000 people died of flu. Now that's one death per 1,000 cases, and we've just come to accept that as a normal state of affairs with the influenza virus, even though we do have safe and effective vaccines, but they're only about 30, 40, or 50% effective. So we hope to look back on this time and say that increased investments in research have led to a greater understanding of immunity and greatly improved vaccines. Thinking back 20 years ago, think what happened with antiretroviral therapy. We've gone from having no treatment to having highly effective treatments. And if we do things right with research and investment with COVID vaccines, we could have greatly improved vaccines down the road. And one vision would be that we have universal vaccines for all coronaviruses and flu. That's something that vaccine science can deliver. And I'll draw your attention to an editorial published in Science just last week by our colleagues Wayne Koff from the Human Vaccine Project and Seth Berkley, the head of Gavi, calling for an effort to develop a universal coronavirus vaccine. So that's the optimistic view I have. Thank you, and I look forward to hearing from the rest of our panelists. Thanks very much.
Great, thank you, Tim. And if you have questions for Tim or the other panelists, by all means, go ahead and put them in the chat, and we'll try to get to those as we go. So our next panelist is Dr. Fiona Atuebwe. Dr. Fiona is the new vaccines medical officer for the Africa region of the WHO, the World Health Organization, focusing on supporting the introduction of new vaccines across the continent, including helping countries prepare and submit Gavi applications for new vaccines. She's been at the front line of the COVID vaccine response, or the COVID response through Africa, and was one of the first medical officers in Africa to go public with her own diagnosis last year. Her most recent achievement is her support in Zimbabwe for the first ever use of the typhoid vaccine in response to an outbreak in Africa. Dr. Fiona has received numerous awards for research and scholarship, including the Joint Japan World Bank Graduate Scholarship and the Ruth Griffith Prize at the University of Leeds. She was trained in medicine and surgery and holds a Master of International Public Health from the University of Leeds, and also studied vaccinology here at the University of Cape Town. Dr. Fiona, over to you.
Thank you very much, and I'm happy to be here. I will now also in the next 10 minutes take you through the process that we have developed as WHO and with partners to get right from the beginning of the manufacture of the vaccine up to the time we get it into the arms of the recipients. So we have 3 ways in which African countries can access vaccines. The first one being the COVAX, which I'll talk about. Then we have the Africa Vaccine Allocation Task Team of the African Union. And then there's an option of countries going out and having bilateral agreements directly with the manufacturers without having to go through any of these other mechanisms. So the COVAX facility is co-led by the World Health Organization, Gavi, the Vaccine Alliance, and CEPI, which is the Coalition for Epidemic Preparedness Innovations. And in a nutshell, what the COVAX facility does is to pool demand so that we have a pooled supply, so that we could assure manufacturers that they will actually be demand for these vaccines, because this is the first time that we are putting manufacturers under pressure to have enough vaccines to be able to accelerate the development and manufacture of vaccines. We have several vaccine trials that were funded and closely monitored by the facility. However, there are vaccines that are still not part of the facility, but have come to sit in our basket right now, and we have a number of vaccines that are being followed up. And once the vaccines are developed and show that they show promising efficacy and safety requirements, then the COVAX works with manufacturers to start securing as many doses as we can that can be provided to us. And so far, that is how we've gotten to getting vaccine to cover about 20% of the African population. However, the COVAX facility will provide these vaccines free of charge for what we are calling the advanced market commitment countries, the low-income countries, and then for the high and self-financing countries, they would get the vaccine but have to commit some funding to it. However, the COVAX facility is not providing any operational funds. Governments have been requested to get out of their way, find domestic financing and other ways. So this is enough to cover high priority groups like health workers, and then after expanding to other vulnerable groups like the elderly and those people with comorbidities. Then we have the AVAT, the Africa Vaccine Acquisition Task Team, that has secured but not really procured about 670 million doses for the African continent. And to enable countries to be able to access these vaccines secured by AVAT, the Africa Export-Import Bank has guaranteed $2 billion funding for countries who wish to access these funds to procure more vaccine in the low and middle income countries. But also we have the World Bank put out $12 billion for countries to also be to access. This is still for the low and middle income countries, and so far we've had countries who have expressed interest in these funds. Now, when it comes to, next please, vaccine distribution, and we know that we require countries to, next please. Yes, so vaccines could be available, but how do they get into the countries? There's a lot that is required before the vaccines get into countries. South Africa is very lucky that you have vaccine in country, but there's a lot of background stuff that happens before these vaccines get into the countries. And countries have three options also. Countries can go, the national regulatory authorities in countries can go ahead and do what we call emergency use authorization of a product that has not been licensed and not been pre-qualified by WHO, or they could rely on the WHO emergency use listing of a product, or they could rely on the emergency use authorization of a product by a stringent regulatory authority. For example, when the US FDA authorized the use of the Pfizer vaccine, then any other country could have gone ahead and made a decision that since a stringent authorization agency like the US FDA has done this, they can also go out. But many countries do rely on the WHO emergency use listing processes before they can authorize in the countries. So we have had so far in the WHO 2 vaccines which have been listed for emergency use. And this is the Pfizer vaccine that was done in December, and just last week we had the AstraZeneca manufactured in the Serum Institute of India, and the one manufactured in Korea that could be used. And right now we are completing the process of vaccine allocations, which will be administered in the first and second quarter, and we expect the vaccines to go out as soon as possible, latest mid-March, and countries should be able to access this. But before the vaccines even get there, now that we've done the allocations and all that, countries need to make sure that some things are in place. Forget the health workers being trained, the cold chain in the countries and all that. But countries must have a national vaccine deployment plan. And these plans include who is our target population, where shall we vaccinate from, how shall we move vaccine from place to place, who will sign when the vaccines arrive at the airport. We need import permits, who is going to grant the import permit, those signatories. For example, some countries delivering an import permit could take weeks. But we are saying that we have the African Vaccine Regulatory Forum, where all national regulatory authorities in Africa they're all represented. And these regulatory authorities came together and agreed that within 2 weeks, all these processes will be done and the vaccine from the time of arrival will be out. So they will expedite the import licenses. Countries have been asked to sign an indemnity and liability agreement with the manufacturers and with the COVAX facility, and that the national regulatory authorizations will be expedited. And this has been done for most of our countries. So when we get to our target populations, we are dealing with non-traditional target populations with the COVID vaccine. We are talking of health workers. For the first time, we're having health workers as the recipients. They are the vaccinators, and they are now the patients. And health workers are human, it must give it to them, because they also get into vaccine hesitancy. We saw, you're lucky to be in South Africa, where people have seen firsthand what COVID can do. In other countries, people still do not believe that the COVID-19 disease actually even exists. And health workers, we have some health workers who still don't believe this. Now, these are the health workers we're expecting to vaccinate, or actually to accept to be vaccinated, and also go out and educate the communities. So it's a lot of anticipation we are having. We are thinking, okay, we really hope that they can, the communication can be done well, and Tim talked to this. The hesitancy is in different ways, and it comes in different ways. In Africa, health workers really are taken as opinion leaders when it comes to matters relating to health. So if we find a health worker who is an anti-vaxxer or is still not well knowledgeable about the vaccine, it becomes a problem. Then we are talking about the elderly. The elderly population is not, in Africa, is not a population that we normally have targeted programs for interventions. We do not have, most countries in Africa don't have, for example, the influenza vaccination. So we do not even vaccinate these elderly people. We do not know where they live. We don't know what they do. We don't even know how many they are and where to find them. So we need to start the micro-planning and putting special mechanisms in place to reach these health workers, these elderly people. We are talking of people with comorbidities. In Africa, in most African countries, it is just by chance that you go to a health facility and you're very sick and you're told you're in a diabetic coma or ketoacidosis, or what you have is a stroke because you had uncontrolled blood pressure. That is a point where most people are vaccinated. But now we are diagnosed. We are talking of vaccinating people with comorbidities. So we have to very rigorously go out and look for these people. Otherwise, throughout the past decades, there's been a lot of tremendous work that has been done, and progress has been made to ensure that people everywhere receive vaccines. But again, we still see vaccine hesitancy. The culture plays a big role in the African continent. The religious background and all that, what people think, what they have heard about the safety and effectiveness of vaccines, like Tim mentioned. The social processes, how do friends behave? What are family members saying? What are the workplace norms? What is your pastor saying? What is your sheikh saying at work? The trust in providers. And we have this big thing in Africa that if the population does not trust the government in place, it may not be about the disease, the vaccine at all. It's about the government that is delivering the vaccine. If the population does not have this trust in the government, then we are in for trouble. Otherwise, thank you very much, and I'll leave it at that for now.
Thank you so much, Dr. Fiona and Dr. Tim. It's been wonderful hearing from you both. So now it's over to our participants. We have a poll that we would love you to participate in. I'll read out the question and it'll pop up magically on your screen. We'll give it about 15-20 seconds and then we'll get the answer. So the question we would love to hear from you is, what do you think the biggest challenge will be to roll out the vaccine? Will it be hesitancy, managing workforce resources, supply chain and distribution, equitable access, procurement, community engagement, or reporting adverse events and reactions? Just give it another about 5 seconds. Sarah, should we see what how our audience feel? Gosh, that's interesting. So hesitancy and supply chain have it. And then Oh, and also equitable access. Thank you so much. Chris.
Great, thank you, Joni. And thank you, Dr. Fiona. Recognize that you're going to have to depart a little bit early today from the panel. So we will, if we don't get a chance to address some questions to you, we'll do that maybe by email later. Our next speaker is Dr. Anban Pillay. Dr. Pillay is the Deputy Director General of the National Department of Health in South Africa. He's involved in procurement and planning for the COVID vaccine rollout across the country. He serves on various national and international policy committees and is a frequent spokesperson for the department, helping to communicate the status of COVID and immunization plans for the country. He served in the national government in various management capacities since 2004. Dr. Pillay studied clinical pharmacology at the Nelson Mandela School of Medicine and has a PhD in health economics from the University of Newcastle in Australia. Dr. Pillay.
Thank you very much, Chris, to the Broadreach group for this invitation and organizing this this event. If I can go to the next slide, please. So I would like to cover today a little bit about vaccine progress in South Africa, and just discuss the suppliers and the supplies and issues relating to the variant, as well as some of the other clinical issues that relate to vaccines. Next slide, please. So the key three areas that I would like to cover is the supply engagement and vaccine efficacy, the impact of the variant, and finally the vaccine rollout. Next slide, please. Next slide. So on the supplier engagements, we've been in contact with a number of suppliers. I think the best known of these is COVAX, and I think Fiona has mentioned how COVAX operates. In addition to that, we've been engaging with the Serum Institute, who provides the AstraZeneca vaccine, and that has posed some challenges for us with the results of the latest study around the efficacy of the vaccine in the context of the variant. We then also have the Pfizer vaccine, which we anticipate we'll be receiving fairly soon. And I think this is a vaccine that poses a number of challenges, particularly to developing countries that may not have the infrastructure to accommodate a vaccine at -70 degrees. So we will certainly be challenged in the rollout of this vaccine. The Johnson & Johnson vaccine, fortunately, has been rolled out in South Africa. Currently, we were blessed to have the support of Johnson & Johnson to share with us the doses of the trial doses of the vaccine that they've shared with us before it actually got to commercial batches. The Moderna vaccine, we've been talking to Moderna about access to the vaccine. The availability of this vaccine is challenging in that it's only available largely in the 3rd to 4th quarter, and the price on this vaccine is as well is significantly higher than the others. The other vaccine, which I think is in the horizon globally, is the Sinopharm vaccine. We know that this vaccine has been submitted to WHO for approval for emergency use, and a number of countries have already started using this vaccine. There are clinical studies that have gone on, phase 3 studies. So I think this vaccine will probably take on a global presence in the next couple of weeks to months. The Sinovac vaccine probably in a similar situation. However, the clinical data around that is still needs to come out on its effectiveness here. The Sputnik V vaccine from the Gamaleya Institute, we've been engaging with them for a long time, and we have a number of questions, particularly around the efficacy of the vaccine in the context of our variant. And then secondly, there's been a number of issues relating to the Ad5 component of this vaccine in the context of a country with a high HIV prevalence relatively. So I think our advisory committee needs to review this data and understand where this vaccine would fit in the South African context. We've also been talking to the other company, Bharat Biotech. Not too much information out of them, but We have been in contact with them as well. They're involved with the Indian rollout. They have developed a vaccine with, along the similar lines as Sinopharm and Sinovac. They've also worked on a nasal application, which we think may be quite promising going forward. Next slide, please. Going into the efficacy of the vaccines, this slide was very nicely put together by Professor Karim, and it maps out the efficacy of the vaccines as we know it in terms of the 501YV2 variant, which we are exposed to here in South Africa. And what you see quite clearly is that when you look at a moderate infection, the Johnson & Johnson vaccine is about 57% effective. However, when it comes to severe disease or mortality or hospitalization, the effectiveness of the vaccine goes much higher to 85%, and in the case of mortality, 100%. So we quite are confident around the effectiveness of this vaccine in the context of the variant. We've had some data around the pseudovirion as well as live assay lab assays for both the Pfizer vaccine and the Moderna vaccine. There are declines in effectiveness with both vaccines, but we anticipate that they will continue to be effective in the presence of a variant. We're still waiting for data around the Gamaleya. As I mentioned earlier, the AstraZeneca vaccine has had a significant reduction in effectiveness, and that's influenced to a large extent our decision to pause its rollout until we understand a little bit more about how it's going to perform in the context of a variant. Novavax, we don't have much information, but the clinical effectiveness seems to suggest that it's about 49%, which is ideally not a vaccine you'd want to choose as your first choice. And the Sinopharm report on the lab-based data as well suggests about a 1.6% reduction, which is anticipated, but hopefully that would continue to be effective against our variant. Next, sorry, next. Sorry, can you have the next slide, please? Thank you. So the question is, do vaccines prevent the pre-existing variants? And I think these variants are predominant in a number of countries still. So South Africa does have the unique problem of the 501YV2 being quite predominant. But in the context of the pre-existing variants, you can see all of the vaccines do pretty well. Pfizer being 95% and many of the others in the 90% range. So in terms of endpoints as well, you can see the vaccines do fairly well. So there's still a place for all of these vaccines globally, depending on the context of the variant. Next slide, please. So do vaccines prevent hospitalization and severe COV2 with pre-existing variants? Here we can see as well, and this is probably the area that we particularly interested in. I think very often when the studies are reported, there's much focus on moderate to severe rather than severe and hospitalization mortality for the efficacy of these vaccines. And I think our main focus here is on preventing hospitalization and mortality as well as severe COVID. And I think those are the endpoints we're particularly interested in. And we can see that most of these vaccines are quite effective in that context. With the pre-existing variants. The picture obviously changes in the case of the 501YV2 variant. Next slide, please. So let's just talk a little bit about the variant. I think it's important to just understand the South African variant. Next slide. The structural analysis of the spike mutation, where we see that the spike protein attaches to the ACE2 receptor on host cells. And each of these three petals of the spike protein carry a hook that's called the RBD, or the receptor binding domain, which is what interacts directly with the ACE2 receptor. So the RBD is the main target of the neutralizing antibodies, which has elicited the COV2 infection. The remaining neutralization activity seems to be targeted at the end domain. And I think this is where the spike mutations have been quite significant in the case of the 501YV2, because it's shown to potentially escape antibody action. Next slide, please. And this is a sequence of the various lineages that our colleagues from the NICD, as well as the team led by Professor Tullio, has been able to isolate. And you can see quite clearly that the 501YV2 became predominant around November, December of 2020, and has basically become the predominant lineage now that exists in South Africa. We anticipate that there will be further variants, and I think this variant clearly facilitates easier transmission of the virus, and until a new mutation, which is probably more effective in transmission, comes along, we're probably going to be living with this variant. Next slide, please. A little bit about the vaccine rollout. Next slide. So we've developed a framework for the vaccine implementation plan at a national level. There are a number of governance structures in place, from a selection committee that identifies which vaccines should be in place. A committee is looking at rollout and distribution, as well as administration. Clearly, one of the key challenges that we have is being able to effectively communicate information to everyone on the ground. This remains a challenge, I think, for us, as information across the sector is a problem, and many people still have questions about the vaccine rollout and how it needs to be effectively managed. Stakeholder guidance is important, and we've tried to bring together various stakeholders: the public sector, private sector, associations of professionals, the labor unions, as well as civil society, to engage around these issues. We've taken an approach of prioritizing the population. I'll say a little bit about that, allocating the vaccine to different groups, defining how distribution would happen, and to the supply the point where vaccines will then be supplied. We've done a lot of work around how administration will happen, as well as the safety, effectiveness, uptake, and where a second dose needs to happen as well. We have developed a data system, which I'll share with you just now about how it works, and that's intended to monitor the supply and track vaccines, vaccine uptake and coverage, as well as reporting on adverse events, so that we will be able to act effectively. There are also a number of regulatory considerations. None of these vaccines have been approved in the traditional way in terms of medicines or vaccines, and so we've had to take alternative pathways like other global regulators have. And the financing and budgeting needed to be quite nimble to be able to respond to the procurement requirements of the vaccine suppliers. Next slide, please. So this is the phased approach we've taken, largely linked to the supply of vaccines that are going to be available in phase one. We're targeting healthcare workers. We expect about 1.2 million healthcare workers to be taking the vaccine. With the Johnson & Johnson vaccine, anticipate that's about 500,000. The balance of that will clearly come from supplies of the Pfizer vaccine, as well as the commercial batches of the J&J as soon as they become available. I think in phase two, we would then move to a much bigger group, looking at essential workers, those in congregate settings, the elderly, and those with comorbidities. So that would be phase two. That's a much bigger group to vaccinate. We time this in line with when vaccines are more likely to become more easily available, which is in quarter two. Then in quarter three is the largest group, who are those over the age of 18. And at this point, we anticipate many more vaccines will become available. and the vaccine suppliers would have adequate quantities. So it would be quite easy to then get these vaccines in country to embark on a mass vaccination program. Next slide, please. Finally, just to share with you our electronic vaccine data system, or what is referred to as the EVDS. In a vaccination program of this scale, critical that you have an electronic system to be able to manage your vaccinations. For a variety of reasons, you want to time these so that people get to the vaccination points at an appropriate time and they know when they need to be there, which point do they get to, the quantity of stock that needs to be available at a particular site for the vaccination. You want to register these vaccinees so that you have a full record of who's been vaccinated. You're able to then deal with any issues relating to adverse events. You can manage your informed consent in this way as well through an electronic system. And where there is a follow-up for a second dose, this can be managed as well. So I think it's a vaccine data system is central to the rollout of vaccines. There always are teething problems with the EVDS, and as they become available, we try and address these. But I think the important thing is that an electronic system is in place that is able to remove the usual manual paper-based systems that have been in place for many of the other vaccinations in South Africa. At this point, I'd like to stop and thank you very much for your attention. Over to Johnny.
Thank you so much, Dr. Pillay. That was really interesting. I can't wait till it gets rolled out for my age group. So we have another poll question that we would love to get everyone involved in. And it'll come up in just a second. So what we would like to hear from you is from our participants, how confident are you that the vaccine will be able to be effectively rolled out within the next 12 months? So are you highly confident, unsure, or you think it's unlikely? Just give it a few more seconds. Sarah, I think we can finish the poll. Wow, we're fairly confident. That's great news. I think, yeah, we probably need to be confident here. Chris, over to you. Introduce our last speaker.
Great, thank you, Joni. And thanks again, Dr. Pillay and our other panelists. Our last panelist is Ernest Darko. Dr. Darko, or Ernest, is the co-founder, one of the co-founders of Broadreach Group, where he leads efforts around finding transformational solutions to radically improve healthcare delivery and to catalyze broader health sector involvement across the continent and globally. Ernest is internationally respected as an expert in health systems programs on the ground, understanding exactly what really does happen on the ground, how do you eliminate impediments on the ground. He's recognized by the New African magazine as one of the 100 most influential Africans and was elected Social Entrepreneur of the Year in 2015 by the World Economic Forum and named one of 18 global health heroes by Time magazine. Ernest also was recently appointed as a board member to the Schwab Foundation. Ernest earned his medical degree and master's in public health from Harvard and also completed an MBA from Oxford University as a Fulbright scholar. Over to you, Ernest, to bring us home.
Thank you, Chris. I think it's asking for the host to bring me up on the video. So I'm not sure if you can see me yet.
Go ahead, Ernest. We're all good.
Okay. Okay. Well, thank you, everybody. So as Chris mentioned, you know, at Broadreach, we've really been obsessed with, you know, the ability to figure out what makes programs tick on the ground on a Monday morning, in particular, programs that deliver healthcare at a large scale with good quality. And obviously, COVID has presented an unprecedented challenge on a global basis for the health community to tackle. And for me, at a personal level, it's fascinating to see this all play out and to hopefully be able to make a useful contribution to this. Can you move to the next slide, please? So, next slide. So achieving herd immunity and achieving it quickly in particular is a massive logistical feat, I think, as you'd all agree. And I just wanted to do some quick back of the envelope calculations to just highlight this fact and to really bring it home into what we're actually trying to do. So if you look at the target announced by the Africa CDC of vaccinating about 780 million Africans over the next 12 months, that would require, if it's a single dose, we're talking about doing 3.5 million vaccinations per day, okay? That translates into 437,500 per hour. And that's for a single dose. If it's double dose, because remember, at some point, people will start to come back for their second dose, while some people are still coming for their first dose over that 12-month period. So it would actually then become closer to 7 million vaccinations per day, or 875 vaccinations per hour, right? So this is at the Africa-wide level. If we take it to the South Africa targets that Dr. Pillay had just shared, South Africa is looking to vaccinate about 40 million people. And again, let's assume we would do that over another 12-month period. Keeping in mind, this 12 months assumes that it's 220 working days, 8 hours a day. And I'll say a little bit more about that in terms of how certain changes may affect those viable operating hours. So with South Africa, 40 million over a year, we're looking at 182,000 vaccinations per day, or 22,750 per hour, or roughly 363,000 vaccinations per day, or 45,500 per hour. So when you talk about having an engine that is this efficient and proficient at delivering something, a lot of things have to go right. In essence, you're talking about a very complex orchestra of different events that must all come together impeccably, right, and be orchestrated impeccably for that event to occur in the right way at the right time in order for us to make it to these targets within a 12-month period. Keep in mind, this is assuming no new variant again comes in where you have to start again, from scratch vaccinating with a new vaccine. So this is why it's so important that we get this right and can ideally contain this while we're on this variant. So Dr. Fiona mentioned the need for micro-planning, and I can't agree with her more strongly. I want to share a little bit of what I've seen go wrong when we try to roll out large-scale vaccination programs in the past. So and I talk about Monday morning, because I always say when the drugs arrive in pallets at your airport, that's when actually your problems begin. So I know we're obsessed with getting the supply at this particular moment, but I think the real challenge begins once the vaccines arrive. And so one issue of storage, in particular storage at the site where vaccinations are being issued, that I've seen occur quite frequently is where the size of the refrigerators or the size of the storage space is too small for the volume of population that you're trying to vaccinate. And this creates massive supply chain issues where even if, for example, there is more vaccine available on site, they can only keep so much at any given time. And this creates huge mismatches potentially in your ability to actually vaccinate, assuming the people are lined up. And as Dr. Fiona said, that's a big if. Will they be lined up as they need to be lined up, in particular, given that we've just come through a phase of telling people don't come to the facilities because of COVID, social distance. We've made them a bit afraid of the facilities. And now we're saying come to the facilities, for example, for that. So the storage issue is one. The reading through the specifications of each of the vaccines, many of them have preparation requirements, for example. One of them needs to be thawed out for 2 hours, for example, before you can actually administer it. So if you want to start your clinic at 7 in the morning, it means someone has to come in at 5 in the morning to start thawing out the vaccines. At this particular point, I know unless it's a 24-hour clinic, most clinics don't start at 5 a.m. So if on the other hand, you start at 7 thawing them out, you then go to 9 o'clock in the morning before you can start administering the first vaccine, and which then decreases those 8 effective hours to 6, which increases these numbers we have to hit on the screen by 25%. Okay, so these are basic things that we need to really figure out quite quickly and early on as you think about doing this. The vaccines, after they've been mixed, have expiration dates. Between Pfizer and Moderna, one of them is 6 hours and one of them is 12 hours. So again, if the people are not there, you have to really, you'll have major issues with losing a lot of vaccine, which we spent a lot of money and effort to actually acquire. All of the commodities and supplies associated with giving vaccines also need to be there. We have to worry about disposal of massive quantities of sharps, syringes, etc. And then recording of information. If we are recording in the patient record or a special immunization card, those need to be printed, those need to be available. I've seen many programs where they basically cannot start because things like the basic paper records were not there, or they weren't in place, and therefore they could not actually start the program. And you'd be amazed at the supply chain to deliver paper to multiple sites at the same time, how that causes so many challenges, or has so many challenges within that alone. And yet the vaccine may be there, but these enablers may not be there. With clients, we have huge issues of just access to the facilities. How are we managing the volumes of those people? How are we managing the queue? For most of the vaccines, colleagues around the world have told me, for example, they implement a 15-minute patient observation protocol. So after the vaccine, you have to be observed for 15 minutes. Where will all those patients wait? Do we have space for them? Are we able to accommodate that within our model or not? So these are some of the things that on a Monday morning, sites are going to face and have to work through quite quickly. Medical staff, we have quite a few issues associated with them. So in many countries, we run into issues of policy dictating who can give an injection and who cannot. And sometimes policy actually functionally decreases the actual people available who can give an injection. So it's something, if in a country where the policy is very restrictive, for example, saying only doctors can give an injection, this is an area where, again, they almost need a emergency use authorization for other staff to be able to do this. And then working hours, as I mentioned, if we're going to have, for example, staff work early and start at 5 a.m., most of these staff have children who need to be dropped at school, or someone who needs to take care of them. And that creates a lot of personal issues for them. But more importantly, in many cases I've seen with things like this, it then raises the issue of, are they going to get extra pay, right? And very quickly you can run into labor issues that end up causing strikes, etc., over issues like this. So this is something, again, to really be careful about and keep in mind as you're planning. And then finally, use of personal data. So Dr. Pillay just mentioned the electronic system South Africa is using, and a lot of electronic systems have been brought to the fore to assist in various aspects of the COVID supply chain. The issue is when any of those technology solutions require staff to use their own personal data, you run into issues. And often you find they do not want to use their personal data for work purposes, in which case then you have to really figure out quite quickly, either you're going to give them a new device, now you're worrying about the logistics of distributing devices to thousands of staff and procuring them, as well as then training them on how to use these devices. So these are some of the things where history has shown us you'll run into on a Monday morning as you try to implement these large programs. And the extent to which we have time to do this micro planning and preparation, we should use it wisely, planning around these things. So one of the things that I would urgently issue as advice is that sites should conduct practice runs or dry runs prior to the vaccine arrival, right? I think it goes a long way in unearthing, this is where we're going to have fall down points, and you can address them beforehand. And then I would say we need to really urgently invest in the right digital and data solutions early on. And so far, what I've observed is countries are only investing in these when they're in absolute crisis mode, which is really not the time, first and foremost, to be making those decisions. But secondly, you will not benefit as much from what those platforms have to offer if we're trying to implement them in the middle of the hottest part of the fire, as opposed to at the beginning, when in many cases they could have actually prevented or tempered the intensity of that fire. Next slide, please. So I took the liberty of taking the South African implementation framework and mapping that against the different levels of interaction with client, provider, facility, and regional or national or international bodies. And then just detailing, these are all of the places where different types of data solutions or data or different modalities are required. Right? So we have from the patient themselves, how we get them the education and awareness. How does a patient know what their priority level is? Are we texting them? Are we communicating with them through media? To how do they get their appointment information to know where to show up? Them understanding, for example, what happens to them during the process, what to expect in terms of side effects. What kind of proof of vaccine? Is that electronic? Is it paper? And then obviously getting them their appointment for the next dose. And ultimately then having them have some kind of modality for adverse reporting if they have an adverse event. So to the extent many of these will require, and you will see technology solutions come into play. For providers and the facility, there's so much data that needs to be gathered, which I don't think can be done on paper. You need to think about doing this through some kind of electronic modalities. The facilities need readiness assessments. The staff need training. They need, as I mentioned, the right space and the right equipment. We need to do stock management and stock visualization so we can triage our stock appropriately. Then, of course, if we're tracking toward these targets, like 40 million in the case of South Africa, 780 million in the case of the African continent, we need to actually assess performance on an ongoing basis to see how are we doing against this target, in particular if it's over a short period of time, like 12 months. So looking at providers at an individual level, if they have standards of how many they need to do a day to hit the target, or the facility performance in terms of how many they need to do as a facility. And then ultimately, all of these need to boil up to provide management insights so that people like Anban can allocate their resources most effectively and efficiently, and also pick up issues and challenges that are arising. Of course, issues like surveillance and mapping are still critical. And then adverse reporting, I think, because in essence, with the rush to bring these products to the fore, in essence, the experiment that still continues on an ongoing basis and the research is on safety. And is there anything that is going to emerge now as we get into the millions of people getting the doses? And then, of course, beneath this, we have data collection systems, data analytics, quality assurance. So in essence, we're not going to develop all of these things just for COVID. Many of these things we can gain from existing other systems that we've invested in the past. The question is, can we make those systems interoperable so that in essence, they can provide value for this COVID use case, right? Now, next slide, please. This is my final slide. So ultimately, in essence, what I'm saying is when you look at all of these different data elements that need to come together, often through different data siloed solutions that in many cases are not interoperable, I think if we try and approach it through this kind of approach where everything is being done separately through hundreds and thousands of different systems, we're not going to get there, because remember that impeccable orchestration you have to deliver on these targets in the right time. So I think we should start to think about this from the point of view of we do need a control tower approach where we're doing this dynamic matching of supply and demand, where it's rational, it's controlled, and it's evidence-based and evidence-driven. And this must be from the global level down to the smallest local level of a community and the associated facilities or providers. And why I think this is also critical, I think we've already seen, for example, countries ordering, 5 times what they need, et cetera. And I think if we had a global control tower type of mechanism, it could have rationalized some of these numbers a lot better from the beginning, saying this is how the maximum amount country X would need. And from a global level, we can drill down to continent, countries, in country, to subnational levels to really define what people need, so that we don't have this kind of, I'd say, initial, I'm only going to take care of myself response, and I'm going to lock in as much supply as humanly possible because I'm only worrying about myself and I've got no other reference point except, myself and the population I'm trying to care for. So this makes it a global approach to a global problem as opposed to a local approach to a global problem. And so we need to manage this in a more coherent framework. And I think from a data and technology perspective, if we look at it from these are the technologies that support our demand, these are the technologies that help us address supply, and then we figure out platforms that can help us, frankly, integrate these and orchestrate them, towards a much more focus and common purposes. It's the way to go. So I think, this functionality and approach, I think is required for all diseases, right? As we look at it now, COVID, I think, is an opportunity for us to improve how we basically run healthcare overall. It's forced us to innovate into areas where previously we probably would have taken 20 years to get there, and now we're doing it, like telemedicine, et cetera. And I think the single biggest mistake we could make is to make COVID yet another vertical disease program, right? Because for example, if we're going to go through all this effort to immunize, the population for COVID, it would boggle the mind that then somehow we'll still be doing badly for all the childhood vaccines we have. So if we're going to put all this effort into improving the system for vaccinations, it should benefit other programs like vaccination, but more importantly, it should benefit diabetes management, HIV management, TB management, because we're interacting with people who have those conditions as well. And it would be a waste to expect a separate, complete different system than to go and take care of those people, again, for those conditions. So I think COVID gives us this unique opportunity to improve our health systems, and we should really take advantage and capitalize on it. So I thank you for your time, ladies and gentlemen, and look forward to the rest of the discussion.
Excellent. Thank you so much, Ernest. And thank you to all of the panelists. Just a couple of quick summarization of the themes that I think we heard today, and then we're going to turn it over just for a few questions. So what I heard, at least was trying to capture in my own notes, was we're looking at a marathon, not a sprint. We talked a bit about vaccine hesitancy and some of the ways to overcome that. We talked about the COVAX mechanism and other mechanisms to address regulatory, finance, and vaccine efficacy issues. We talked about the variant that we're experiencing here in South Africa and some of the ongoing challenges this causes us to face with respect to catching up with our vaccines. And then we ended with Ernest's conversations around what I think we heard is micro planning, really focusing at the, what happens on Monday morning when the pallets arrive. And then just to end off on that, don't make COVID another vertical disease program. Good luck with that in terms of our US funders. But that's just a few summary points. Why don't we, Joni, turn it over for just a few quick questions that we have before we finish up at 1:15.
Sure. Thanks, Chris, and to the panel. I've just tried to pull out a few key questions and sort of themes that have been asked widely for comment on the panel. Lots of people have been asking about some kind of concrete things that we can do to address vaccine hesitancy. Does anyone on the panel have some?
Maybe we should, I know Tim Mastro presented a bit on FHI's approach to that. Tim, you want to address that?
Yeah, no, thank you very much. And I think we're going to have to build on the global experience with vaccine hesitancy, which is not at all new. It's new for COVID because COVID is new. And I think the social behavior change methodologies we proposed really are sort of iterative. They're very consultative and collaborative. So you have to deal with the organizations addressing the challenge. You have to deal really with the community and understand the community and perspectives on community. And then it becomes a process of doing an assessment, what kind of perceptions do people currently have? If there is misinformation, how can that misinformation be addressed? And then even more toxic really is disinformation, when you actually have anti-vax people intentionally spreading disinformation, which is falsehood. So that's happened already with COVID. So it's really an integrated approach really with the stakeholders in a country. Countries may have a very different dynamic that has to be addressed. And I think that the quick start guide that I talked about has a good layout of how those steps could be implemented at the country level.
Great, thanks, Tim. And Dr. Pillay, would you like to add anything to that? We might have lost him.
Sorry, I'm muted. Sorry.
Go ahead.
One of the challenges around hesitancy is trying to share information in a manner that is easily understood by the public. I think one of the problems we've had is that we share scientific information because we want to be precise, particularly in terms of the science. But in the process, we lose a lot of people who don't really understand what are we trying to say? What does it mean for them? And I think we have to get down to simple language that everybody understands, because I think that's where we lose people along, particularly in the case of vaccines. Yeah, thanks.
Great, thank you, sir.
Chris,
Yeah, go ahead, Ernest.
Let me add just something briefly. The numbers I went through, if we say that's indeed the target that we have to hit to achieve herd immunity within a given period of time, the issue of hesitancy becomes really critical, because that's not something you're able to solve quickly, right? Changing people's minds, changing their belief structures takes time. So this could really hamper us if it gets to significant enough levels that it starts to affect the accessible population from the point of view of willingness. Forget about the logistics of them actually then getting to the vaccine. So I think any time countries have where the vaccine is not yet in play and they've got some time to plan, this is something where focusing on engaging the communities very aggressively now, this is the time to do it, not when the vaccine has already arrived, because most of it will expire in that case if they wait too long to try and engage on this issue.
Great, thank you. Joni, one more question.
I keep reading the questions and Dr. Pillay keeps typing all the answers and they keep disappearing from the screen. So I'm trying to, sorry, I'm just trying to address another question. So one of the questions that's come out in different formats is looking at the global mechanisms for the vaccine, and then asking, are there other mechanisms for acquiring some of the other things that are needed for vaccines, like the syringes and the kind of supplementary equipment, and how are we going to do that and make sure that it's not used as sort of a diplomatic soft power tool.
Got it. Yeah, and Dr. Fiona would have been great to address that from the WHO perspective. I believe she's already gone, but maybe I'll just ask any one of our other three panelists if you have a thought that you'd like to share around that.
I can probably share our thoughts around it. I think that the consumables that are required to support the vaccine rollout are critical. They are often an area that's neglected because everyone focuses just on the vaccine and forgets about the syringes and needles and the right sizes and the diluents that are needed, etc. And I think much more focus needs to happen on that area. There are certainly supply constraints in that area as well. You may well end up in a situation where you have vaccine, but you don't have syringes, needles, or diluents to roll out the vaccine. So I think it needs to be part of a package. And I think it's very important that countries have quantitative estimates of these upfront. So when they order the vaccine, they're also ordering some of these other consumables that are as critical to deliver the vaccine into the
Great, thank you. Any other quick comments from Tim or Ernest on that?
I think, Chris, this is Ernest. I think, again, just to reiterate, I think once again, like everything we're seeing in terms of the challenges, nothing is essentially new, if you know what I mean. At a fundamental level, we're not talking about brand new challenges that never existed in healthcare. Most of these, we've been experiencing them in other programs as well. I think COVID has just brought that urgency, and really coalesced the mind around the need to solve these things finally in a much more comprehensive way. And I think as bad as it is, I think we should really focus on it being an opportunity, but also give ourselves a break at some degree, that there's going to be a lot of learning, there's probably going to be a lot of mistakes, and we need to be patient with that, because it's such a massive undertaking that, by definition, there's going to be some missteps along the way. As long as we have a quick way of learning and turning around those learnings, back into improve the way we're doing things, I think then that way we'll make it.
Great, thank you, Ernest. And I would just close, I guess, maybe going back to what we heard from Tim Mastro at the very beginning was just his last slide, really imagining a future a few years from now when this is now a routine, a way of being in the healthcare space and delivering regular immunization programs, and that we can actually learn from this and actually address many of the other issues, whether it's childhood immunizations or others. So positive day in the future and a way to look at the light at the end of the tunnel. Let me just thank all of our panelists again, Tim Mastro, Dr. Fiona, who had to leave us a little early, Dr. Pile, and Dr. Ernest Darko, our own Broadreach Group co-founder. Thanks so much to all of the panelists. Thank you for all of those who have dialed in and participated and listened. We look forward to continuing to stay in touch with you and hearing your thoughts and ideas. We will be putting together a summary paper that we'll send out to anyone who signed up for the webinar today. That'll just summarize all of the conversations that our different panelists had. So look out for that, and please stay safe and have a great rest of your day. Thank you so much, everyone.
Thank you.